I cannot hear anything from your side, from India. I cannot hear.
Can you hear me now?
Yes.
Can you?
I can hear you. Yes, I can.
Okay.
Okay. Can I start this transmission? Are you ready? Tejas?
Yes, we are ready.
Okay.
Yes,
Okay.
yes, absolutely.
Okay. This is OCT live transmission from Kamakura to India. We have this meeting to promote the first mutual friendship between our side and India.
Yes.
I and Tejas are very, very long friends, maybe 25 years, very long friends. And I'm very glad to have this opportunity to get the further friendship between you and me. Okay. And we are preparing for 3 cases for this transmission. And also from Kamakura, we have 3 speakers, young generation speakers in the interventional cardiology. And also from your side, India, you can have, maybe you let some lecture to us. Thank you very much.
Thank you.
Okay. You know, almost 25 years has passed from first meeting with you. I got very old. Every year I'm getting older and older.
You are never old.
Today, I will treat only 1 patient, and 2 young physicians will treat 2 patients. Okay? So I want to introduce the first patient. This is 85 years old gentleman who presented with effort angina, severe resting angina with troponin elevation. And we did angiography 10 days ago and found triple vessel disease. The main target today is proximal LAD lesion. It looks calcified. But before treating that lesion, I will treat proximal circumflex lesion. And I will do not touch the right coronary lesion because patient kidney function is very limited. So I do not want to spend too much contrast. And first, I want to show you from myself how to do distal radial puncture. Okay? And distal radial puncture is quite common, very popular in Japan. And we have, of course, we have 2 major methods. One is just touch and feeling puncture. But today I want to show you how to make a puncture with echo guide. Okay? Maybe you can see some echo image.
Yeah.
You can see?
Yes.
Okay, good. So I will make a puncture with echo guidance.
Yes.
Okay. So in this method, I'm always make a penetration of the needle from anterior wall to the posterior wall and gradually removing. Okay. So fortunately, my puncture was successful. And I'm putting 6 French thermo guiding catheter.
Dr. Saito,
Yes. Yes.
who says you are old? Who says you are old? You are very young.
Huh.
Sanjay is here. Sanjay wants to say hello to you. Good morning. Hello. Dr. Sanjay. Good morning.
Sanjay,
I include you. Sanjay. Yes.
the voice communication from your side is not so clear. It's very difficult.
Same here.
Anyway,
Same here.
hello,
Here
hello,
also.
Sanjay. Yeah, hello, Sanjay. I can see you very well. ペッパーに入ったペッパーに。はい Hmm?
Distal radial puncture using ultrasound. वो इजीली कर सकते देखा है.
Okay, this is 6 French EBU 3.75 guiding. And you can see very heavy calcification in both LAD and circumflex arteries. Okay.
Selective.
Okay. I will take a picture. So you can see there is a total occlusion in the distal circumflex artery. But it is very nicely collateralized, so that I do not want to touch that. But another region is the proximal circumflex. I will touch that. And then I will go to LAD. Okay? I take a turn track wire from Abbott. This is a new wire from Abbott next to the BMW wire. 四国のこれ。
Sir, answer.
Okay.
Are you using this wire regularly, Dr. Saito, as a workhorse wire nowadays?
Yes, one of them. Of course, we have many different wires in Japan. Some of them are made in Japan, and we are using several types of wires from different companies. Of course, this is one of the workhorse wire. How do you think about this wire? To test.
Somehow, I have tried a few, but I was not very comfortable with this wire.
Okay, which is your workhorse wire? Which one?
Nowadays, run through extra floppy the workhorse wire in Apex.
Okay.
Yeah.
Okay, so for this region, I will do just only balloon and stent. So the size of the vessel is maybe 2.5. So I predilate with 2.0 millimeter balloon. あ、そっか。そっか、そっか、そっか。Okay, I'm sorry. I was confused for the program. So initial plan was to have a lecture, OCT lecture, from my young colleague doctor, but I skipped. So after finishing some procedures, I asked my colleague to do it. Okay?
Okay.
Sorry for that.
Okay.
This is a real life. So, okay. そうか、すっかり忘れてた。
僕の声聞こえますか？マイクで。
今は聞こえてるよ。
聞こえますか？
あ、でもマイクじゃないな、これ。そうか。
Dr. Patel, can you hear me?
Yes. Yes.
This is Mizuno speaking from Shonan Kamakura Hospital.
Hello. Yeah.
Hello. I work here as a moderator today.
Okay.
So original schedule said that 3 lectures and 3 procedures are set today.
Yeah.
However, as you know, Dr. Saito already started the first case.
Yeah.
So
yes.
after finishing this case, so we will provide a first lecture from this hospital, and then could you have your presentation
no problem.
concession? Are you okay?
No problem. That is after first lecture. You want me to deliver the second one as mine, right?
Okay. Yes.
16。OK。2.5 でいいか。じゃあ 2.5 の15。So I place stent, giants, 25 by 15.
Sierra? You are using Sierra?
Yes, Sierra, yes, Sierra.
How do you find Sierra?
This is much improved compared to the previous generation.
Okay. Okay.
Okay, this is the Sierra. What is the meaning of Sierra? It's a Vedic name? No? I don't know.
I don't know.
Okay.
Silent for sure.
Oh, still, it's very difficult to cross. I think the region is also classified. So what is the plan for the next one? Anyway, I took out the stent, and maybe we need further dilatation first. NC の2ミリ. I take the high pressure balloon, 2 millimeter high pressure balloon.
Which one?
This is a track, NC track.
Okay, track, NC track.
Okay, I take 20 atmospheres. Hi.もう一回. Okay, then try stent implantation again. Still, I cannot cross. Okay, almost.
Oh.
It's still very difficult. So in this situation, I want to take extension catheter. Okay?
Which one are you going to use?
I think どれがいいかな? Hmm? ガイドプラスある? でバルーンで突っ込むね。バルーンで突っ込むから。Okay, this time I will take the guide plus I don't know whether this is available in India or not.
No.
No, okay.
Is this a Japanese brand?
Japanese, yes, Japanese.
Yeah, it's not available.
And also, I will place the balloon inside. Balloon. Okay, you see extension catheter, and
yes,
I will push the balloon inside. The balloon is coming, and I place the balloon here and inflate 20. And okay, deflate. Okay, already extension catheter closed up to the half part.
You are inside the region.
Okay, extension catheter is there. So I will remove the balloon and put stent.
Dr. Saito, the extension catheter is actually across the lesion, right?
Yes, cross the region. It's very nice.
Before guide plus.
Okay, still the extension catheter is there. So
yeah.
I will take cine very easily. And then I will remove the extension catheter. Okay. I think the stent is a little bit too deep. So I pull back stent a little bit. Like this.
Dr. Saito, what do you think is the reason for stent not going in? You think there is a calcified sort of nodule or something?
Maybe, yes. But the vessel size is not so large. So for this region, I did not do any ablation. Okay. But normally for this kind of region, I will take a rotablator or coronary atherectomy device.
Do you have intravascular lithotripsy? Shockwave?
Yes, but only for clinical trial. And I'm a PI for this Japan trial.
Okay. We have started working with that technology in Apex last 2 months.
Oh, really? Yeah. That's great. It's very, very effective. We have enrolled almost 100 patients in Japan.
Yeah.
20 atmosphere. Okay. But how do you think about the lithotripsy shock wave? I think it's very effective. However, it's very good, nice device for the region with 360-degree calcium.
Exactly. Yeah, you said it. For 360-degree calcium, it is excellent, but for eccentric calcium, it may eat lot of pulses without any effect. That's what in initial experience we are seeing that.
Yeah. I totally agree. Okay, for the SAC, we have already finished. And then I'm going to LAD. Okay? じゃあ、あれ、あのワイヤー、なんだっけなんだっけバイパーワイヤー。So, まだ大丈夫 For LAD, I want to take the orbital atherectomy. So this is a special wire for orbital atherectomy. This is, I think, a kind of nice wire.
So when do you choose orbital atherectomy over rotational atherectomy?
Okay, nowadays we are taking orbital atherectomy much more frequently, maybe 10 to 1 against
10 to
1. Okay. I take a picture. You know, the region is very simple. To test. Okay, I will remove the wire from SAC. Then my approach is to take a picture, OCT picture for this region.
Dr. Saito, I think in your lab, 100% cases must be undergoing imaging. So what is your ratio of IVUS versus OCT?
Okay, that's a good question. In my hospital, the ratio is almost 4 to 6. 4 OCT, 6 IVUS. And against CCI, we are doing 100% imaging modality. You know,
yeah,
100%.
That's what. 100%.
Okay, here. Manual? いい？はいはい。はい。
Yeah.
So, Nori, could you make a comment? Nori?
Yeah.
Okay, my colleague Nori will make a comment for this region.
Okay.
He published a very famous article on JAK, Euro intervention, JAK intervention, about the BBS 5 years follow-up. 大丈夫?
Yeah, 60 degree catch.
Nice to see you, Dr. Patel. I'm Noriaki Moriyama.
Yeah.
Please call me Nori. So,
thank you.
This is the first OCT pullback for LED lesion. As you can see, this is part of the diagonal branch. I think this part has some calcification, but almost healthy. This is just eccentric, mainly including fibular plaque tumor. And then we move on to the lesion.
Oh.
As you can see, there 360-degree belly thick calcification. As you can see, this is a very good indication for, I think, orbital atherectomy. And then we are going to continue pullback. And this is the proximal lesion. Still, we can see 360 very severe calcification. And lesion length is from here and maybe here. I think lesion length is around 24, and inner lumen diameter is around 2 millimeters. I think this lesion is good indication for ablation by orbital atherectomy. How do you think?
I absolutely I agree. But Nori, are you able to define the proximal and distal reasonably good landing segments? Because I don't see small segments proximally and distally.
Sorry, I cannot hear from you very clearly. So please, pardon, please.
Acceptable. Yeah. This is calcium, a lot of calcium there, but yeah.
Okay, I think the lesion length is almost 25, no? And especially for the distal half, has a very, 360-degree calcification, and proximal part is a little bit better than that. But anyway, severe. Okay, this is a dynaglide mode. Very low speed, but still rotating. And its rotation reduces friction. And normally, we can cross the region by using this mode very easily. Okay? And our major technique is not pushing, but pulling back. That is totally different from rotablator. Okay. Okay, I will start. そうそう、それぐらいでいいかな。もういいよ、いい。Okay, you can see some ballooning part there.
Yeah,
Okay?
yeah, yeah.
That is the portion which abrade. So I'm starting from the, very slowly with pulling back.
Pulling back.
It's jumped. Okay. So I start again. Jumped. Some EKG change. You can see?
Yeah.
Atropine 半分ぐらい入れましょうか。And some blood pressure drop. So I have to wait. And we give atropine. アトロピン1アンプルですかね。まだアトロピン効いてこないな。少しハートレート上がってきたね。
Dr. Saito, what is the COVID situation at Kamakura and in Japan?
COVID is,
yes.
Everybody is wondering COVID-19. But from the 1st October, from several days ago, the company, the government started to state, we can go to travel within the country. So many people are, going to travel, and many people are also getting afraid whether the COVID is still stable or not. OK. ノルアド入れようか。ちょっと低いね。So blood pressure is still maybe 70, 80. So hopefully we want to 100 mercury more.ちょっと低いね。 100. Okay. We start the ablation. ちょっと深く入りすぎた。Okay, I start.もう一回行くか。どこだよ、どこだ、うん。ちょっと、造影して少しちょろっと。造影。見えない。まあいいや。はい、もういいか。OK。
The blood pressure is very high.
Yeah.
Adrenaline.
じゃあどうしようか。OCT。So, at this moment, I repeat the OCT.
Yes.
How about the COVID situation in India or in Gujarat?
Yeah, in Gujarat and in India, I think there are cases, but people are not afraid of COVID now.
Okay, great.
And mortality somehow has gone down remarkably. There are cases, but mortality is significantly. Yes.
What is the reason for the decrease in mortality?
I think the identification and early that is remdesivir and tocilizumab, these are the two drugs which are making a lot of difference with steroid.
Oh, really? Really? Okay. Hi. Hi.
Is it a hand injection or you inject with injector while you are taking OCT?
Mechanical.
Okay.
Any comment?
And nice ablation. It's a good. I think if you open it up with a balloon, it should open everywhere. I can see small ablated calcified tissues on the surface. So I think that the orbital aspectomy has done its job well. I think with balloon it should open up very well.
Which do you prefer between the simple balloon, high pressure balloon, and the scoring balloon, cutting balloon?
And I think I will use a non-compliant balloons, never simple balloon with calcium. No,
okay.
Non-compliant, either NC track or NC emerge or something. Yeah.
Yeah. High pressure balloon. Huh.
We are not able to hear you. How we are to hear you? Yeah.
275の15のNC トラック。
As you pointed out, I'd like to recommend non-compliant balloon dilatation or cutting balloon inflation.
Okay, thank you. So I'm taking 2.75 high pressure non-compliant balloon NC track. Hi, 20. はい。20 atmospheres. はい。20 atmospheres. はい。well dilated. Okay. はい。One more. Okay. 20. はい。I think now it's time to place a stent. Okay, I will take angio. Okay, so maybe 25 by 33.
Yes, Dr. Saito.
Hi.
Based on OCT finding, I totally agree.
With
I think good stent length is 33 because the lesion length is more than 30.
Yeah.
And the distal part of the lumen is a little bit smaller than 27.5. But by basing on the angiography, our 2.75 millimeter stent is enough. But I think we need post dilatation by using 3 millimeter as the proximal part.
Okay. はいはい。で、あと NC の 3ミリの用意するですね。NC トラック。
Dr. Saito, you don't have real ideal landing zones on either side. There is fibrosis and
the distal one is just proximal to the second septal branch. Okay?
Yeah.
The proximal landing zone should be the, how to say, between the ostium of LAD and the small diagonal. in the center. You agree?
Yeah.
와이어 도구. 나이스. 抜けちゃった. Oh, I lost the wire. 컨트롤 できねえな. Okay, I change the wire.
Which wire you taking now?
I lost the wire position, and so I'm coming back to the regular wire. In the
But we did not hear which wire you are using now.
This is
Minamo.
Correct? なんだっけ? Wire. え、水面なの? 水面出したの? 何か? This is a wire from Asahi Intech. I asked the Abbott wire, but they misunderstood my instruction. ちょっと
section.
Yeah. Okay, this is the stent.
Finding trade.
Okay, yeah. で、NC の3ミリ出した？ 16。はい。 This is a 3 millimeter balloon, NC. Honestly. Hi. Hi. 16。はい、20。はい、OK。So I post-dilate it with 20 atmospheres for proximal parts by using 3 millimeter balloon, NC. And then this may be final OCT exam. Hi. Hi. Hi.
So I'd like to review final OCT. We can see some minor dissection at the distal part of the stent, but I think stent expansion is beautifully demonstrated by OCT, and distal part of the stent is round shape. At this part, stent is some deformation due to severe calcification, but I think this is acceptable. And when we look at the proximal part of the stent, proximal part of the stent is roundly expand, and there's minor calcification. I think this finding is clinically acceptable. But just now I found some new lesion of the ostial LAD.
Yeah.
But maybe this is a future target of our next in the next session.
Okay.
I think.
And very importantly, we do not find any dissection at the proximal part of the stent.
Yes, I agree. We can only minor
and
injury.
At the ostium of LAD. Yes.
There's no dissection.
No dissection. So we can leave it. Okay. So I will not touch the ostial LAD. And I will take the another projection. Should be final shot. Hi. It's very flat region for proximal LAD. So
you are always considering the tapered reference, or you choose between dual reference and tapered reference when you have to see the expansion. And traditionally, as per the guidelines, they say that it should be minimum 80%, but many times, despite the best of the efforts, you see good result, but the expansion seen is 70 or 65 or something. So that is something which we really need to, redefine, because with tortuous arteries, Dr. Saito, we have many times seen that the result is excellent, but somehow the computer reads it differently, and the expansion seen is 55 or 60. So I need Nori's comment on this, Dr. Nori's comment. Yeah.
Nori?
Moriyama.
Nori, you had a question.
So should I repeat the question?
エクスパンションがね、なんだ、僕もよくわかんなかったんですけど、70%、80%だと。68どこにある？Expansion is 68% here.
Yeah.
Yes,
Yeah.
as you pointed out,
Right.
our expansion rate is very important, but I think this is a very classified vessel, or sufficient expansion is very difficult without shock wave. So, in
Yeah,
this particular region.
that's
So
right.
I think this part is this result is clinically highly acceptable. So
Yeah, that is what I also feel.
procedure.
Yeah, that is what I also feel. But you know, this is very important message, because many young operators are chasing for 80% minimum expansion, and in the at the end either you come out with a significant prolapse inside, or you may perforate the arch. Thank you, Dr. Saito.
Okay, thank you. So.